Welcome to Midwest Insurance Brokerage Services video on healthcare reform, a step-by-step guide to the Affordable Care Act. Please visit our website at www.mibsga.com to find more updates on healthcare reform and other resources to help you in your business. Please note that this information is for illustration purposes only, and your client should consult their accountant and/or lawyer for final guidance. The Patient Protection Affordable Care Act, or ACA as it's now referred to by regulators, was passed into law on March 23, 2010. This date is very important in establishing a group or individual plan's grandfather status. If a plan was written before March 23, 2010, and makes no material changes, they can remain grandfathered and do not have to abide by all the provisions in the ACA law. So what constitutes a material change? The first thing is decreasing benefits by more than 15%. This means you couldn't increase a copay from $20 to anything more than $23, or increasing a deductible from $1,000 to anything more than $1,150. Since no plan options really exist with these benefits, in reality, any plan change decreasing benefits resulted in a loss of grandfathering status. The second thing that can result in a loss of grandfathering status is increasing the employee's portion of premium by more than 5% over last year. The first big block of changes that came into effect started October 23, 2010. They're commonly referred to as the 6-month reform changes. They apply differently to non-grandfathered versus grandfathered, group versus individual. We will use this chart to go through each one. The first 6-month reform prohibits insurance companies from placing a lifetime dollar amount cap on the amount they would pay out per person. This was removed from non-grandfathered and grandfathered plans, group, and individual. The next removal was annual limits. It removed the restrictions on annual maximum benefits for certain services such as physical therapy, occupational, and speech therapy. It was removed for non-grandfathered group and individual plans and removed only for group grandfathered plans. Individual grandfathered plans can still restrict these benefits. The third 6-month reform regards children pre-X. It prohibits pre-existing waiting periods on children under age 19. This was applied to all non-grandfathered plans, group and individual, and only for grandfathered group plans. Individual grandfathered plans can still have a pre-existing condition waiting period on children under 19. The fourth 6-month reform addresses preventative care. It provides 100% coverage for defined preventative services. This was applied to non-grandfathered plans, group, and individual. The last 6-month reform addresses dependent age. It allowed dependents to stay on their parents' plans up to age 26 regardless of tax status. This was applied to all plans, non-grandfathered and grandfathered, group, and individual. Summary of benefits and coverage, effective September 23, 2012. This is basically a nutrition label for health insurance plans. Creates a standardized highlight sheet for all plans, grandfathered and non-grandfathered, group, and individual. The summary of benefits and coverage, also referred to as an SBC, must be given to a member in a group market prior to enrollment, at renewal, 60 days prior to an off-renewal plan change, or upon request by the employee. This means as soon as possible, but not later than 7 days from the time of the request. With the induction of the SBC rule, if a group wants to make an off-renewal plan change, they can still do so. However, they must give the employees and therefore the carrier at least 60 days notice. In the individual market, an SBC must be given to an individual policyholder upon enrollment, at renewal, upon request, or 60 days in advance of a material change in benefit. This will be given straight from the carrier to the individual policyholder. We now move into our 2014 changes. The employer requirement to provide health insurance states that every employer with over 50 full-time equivalent employees provides essential minimum coverage to all full-time employees. Full-time employees are defined as 30 hours or more a week under the ACA law. This provision applies to all groups regardless of grandfather status. If a group is over 50 FTEs and does not provide coverage, they will face a no coverage fine. The fine is $2,000 for every full-time employee, not counting the first 30. For example, if an employer has 70 full-time employees, the fine would be 70 minus the first 30, or 40, times $2,000 per employee, or $80,000 annually. Groups with under 50 full-time equivalents will have no financial penalty if they do not provide coverage. So how do we calculate the full-time equivalents? Here's the equation. First, we want to calculate the number of full-time employees working 30 hours or more a week. Second, we need to calculate the number of total hours worked by all part-time employees in a given month. We then take the number of part-time hours and divide by 120. 120 is 30 hours a week times 4 weeks. This gives you the number of full-time equivalents your part-timers add up to. You're then going to add the total in step 1, your number of full-time employees, and step 3 to get the number of full-time equivalents. If the number of full-time equivalents is over 50, the group is subject to a fine if they do not provide essential minimum coverage. Another part of the employer shared responsibility fine applies for groups with over 50 FTEs. If an employer does offer coverage, but the employee-only portion of premium exceeds 9.5% of that employee's annual household income, and one employee from the group receives a premium tax credit when purchasing individual health insurance coverage, the employer will be fined. The 9.5% of annual household income only applies to the employee-only portion of the premium and does not apply towards dependent cost. The fine the employer will face is $3,000 per employee receiving a tax credit, or $2,000 per full-time employee not counting the first 30, whichever is less. Another one of our 2014 changes is the 90-day maximum waiting period rule. It says that the maximum waiting period for a new hired employee cannot exceed 90 calendar days for group health plans, both grandfathered and non-grandfathered. Be sure to check with your carrier for specific rules to see how this may affect your group. Starting in 2014, all non-grandfathered plans, group and individual, must provide essential minimum health plan benefits listed below. While group coverage usually includes a lot of these benefits, individual policies may not, causing benefits to increase dramatically, notably maternity, mental health, and oral and vision care for children. Also starting in 2014 is a guaranteed issue individual market. All non-grandfathered plans under 65 will be guaranteed issue with no pre-existing condition waiting period. There will be no declinations or exclusion riders. Carriers will most likely have 2 annual open enrollment periods, with off open enrollment available for qualifying events such as loss of coverage. Rating for these policies will be based on community rating, which means there will be no health status. So what exactly is community rating? Non-grandfathered policies, both group and individual, can only be rated on the following 4 factors. The first is family size. How many people are on the policy? The second, geographic location. Your zip code when we quote the policy. The third, smoker status. There's a 1 to 1.5 ratio, or a 50% rate up for smokers. And the fourth is age, of a 3 to 1 ratio. There will be no rating for health or gender included in the policies. All non-grandfathered plans will fall into one of 4 metal tiers based on the plan's actuarial value. The actuarial value of a plan is the percentage of total average cost for covered benefits that a plan will cover. This is not the coinsurance of the plan. There are 4 metal plans that will be available. The first is Platinum at a 90% actuarial value, or AV, Gold at 80% AV, Silver at 70% AV, and Bronze at 60% AV. The theory behind the metal plans in the AV is so that consumers can compare apples to apples and look at many different options within the, for example, silver metal category, and compare plans across carriers that have similar benefits. There are 2 types of subsidies available starting in 2014. The first is the individual premium subsidy. It is only available for plans purchased through the public marketplace or the public exchange. Premium subsidy caps the premium amount as a percentage of annual household income based on the client's percentage of federal poverty level. Subsidy is available for those making up to 400% of FPL. The chart below shows a breakout of a percentage of federal poverty level and the cap of premium for that percentage. For example, if you look at the bottom line, it shows 300 to 400% federal poverty level would pay no more than 9.5% of their annual household income on health insurance premiums. The premium subsidy is applied to the premium for the Silver plan. Here is a chart of estimated income level for federal poverty level in 2014. A household of 1 can make up to $46,000 and still receive a subsidy from the government. A household size of 4 can receive up to $94,872 and still receive a premium subsidy. The second type of subsidy available is the out-of-pocket subsidy. It is only available to plans purchased through the public marketplace. It works just like an HRA or health reimbursement arrangement. The government will reimburse a portion of the out-of-pocket that the client exceeds. It's available for those making under 400% federal poverty level and only available if a client purchases a silver plan. Looking at this chart, it shows the out-of-pocket subsidies available for the percentage of federal poverty levels broken up into 3 categories. If we look at the last one, it shows that someone making 300 to 400% of federal poverty level will be capped at 2/3 of the HSA contribution limit. That means this individual will not pay more than $3,987 in a given year in out-of-pocket expenses. If he or she goes over that amount, the insurance company will be reimbursed by the government for any out-of-pocket expenses. The public marketplaces, formerly referred to as the public exchanges, are government websites. They are set up either by state or federal governments where insurance companies can sell plans. Each state decides if they would like to set up their own website or use the federal version. Illinois will have a partnership exchange or partnership marketplace for the first 2 years and transition into a state-run website in 2015, per Governor Pat Quinn. For individuals to access their premium subsidy or out-of-pocket subsidy, they must purchase their plan through the public marketplace. Accessing the subsidy. Employer coverage could affect how an employee accesses the subsidy available in the exchange. If an employer provides affordable health coverage and coverage is deemed affordable, the employee is not eligible to receive a subsidy. Coverage is deemed affordable if the employee only portion of premium does not exceed 9.5% of the total annual household income. This does not include spouses or dependents' portion of the premium. If the employer provides affordable coverage, then the employee is not eligible for the premium subsidy available through the public marketplace, even if they make under 400% of federal poverty level. Starting January 1st of 2014, each individual must prove that they have essential minimum coverage when filing taxes or face a penalty. The fines will be phased in starting in 2014 and fully implemented in 2016. In 2014, the annual penalty is $95 per adult, $47.50 per child, up to a family max of $285 or 1% of family income, whichever is greater. In 2015, the fines raise $325 per adult, $162.50 per child, up to a family max of $975 or 2% of family income, whichever is greater. In 2016, the fully implemented annual penalty is $695 per adult, $347.50 per child, up to a family max of $2,085 or 2.5% of family income, whichever is greater. The fine is prorated monthly for any month you do not have coverage. Having coverage for one day of the month counts as having coverage for the entire month. The last provision we'll touch on are the small group deductible limits. These are effective January 1st, 2014 for all non-grandfathered small group plans. It limits the deductible for small group 2 to 50 lives to $2,000 per individual and $4,000 per family. It makes an exception for plans that do not meet the minimum AV. In a report released in November of 2011, the IRS found that approximately 98% of individuals currently covered by employer-sponsored plans have an actuarial value of at least 60%. Until carriers release their 2014 ACA-compliant plans, we do not know if an exception to the deductible limit provision will be made. Regardless of exceptions, all non-grandfathered group and individual policies will have to make a plan change into a 2014 ACA-compliant plan upon renewal come 2014. Please note that this is for informational purposes only and does not contain every provision in the ACA. Please consult your accountant or lawyer for final guidance. It is a new healthcare world, but one we can conquer with the right education and resources. Stay informed by visiting our website at www.mibsga.com or by calling us at 847-427-8000 with any questions you may have. We look forward to working with you for many years to come. Thank you so much.